This is a 6-year-old girl who has again a bilateral cataract. We examined the parents. They don't have anything. But only thing you can look at here is the morphology. You can see that triradiate opacity with the multiple minute opacities within the lens. So little bit of atypical morphology, and she fixes very well, and her fundus is visible. Her visual acuity is not so bad. It's 660, but still she needs, it's visually significant. She needs surgery. We are going to implant. She is on the axial length point of view, she is on the little bit higher side. 25.04 at this age is little bit unusual. In view of that, we are going to implant a 14 diopter lens in this particular case. So only thing which is atypical here is the morphology. You will see as we are going forward. You can already see in the red glow. You can see it's almost not visible without a colliminator.
And you did a full EUA on this child before you began with biometry, correct?
Yeah.
So what did you find out?
So one of the things we did not do a complete one. If infant is there, if the child's age is less than 1 year, then we will do a corneal diameter, we'll do a gonioscopy and the intraocular pressure. In this patient, everything else is normal, so we would not do a detailed anesthesia in this particular case. So this is the myringotomy opening on one side, and that's the second side. Just an entry is enough. Again, we'll try with the same capsulorhexis forceps if we can. Otherwise, we'll extend the wound.
And in children, do you ever use trypan blue? Do you ever feel the need that you need a
stain? Yes, my trainees use in every case. Personally, I use in only in total cataract cases. But I definitely suggest that everybody should use trypan blue. I personally don't use it because once you get experience, you want to be as minimal in terms of injection of intracameral agents. Try to avoid it. Otherwise, I would suggest all the trainees till they get experience, they should use it. So what I've done is I've inflated the anterior chamber now. So you can see this minute opacities within the lens. It's very unusual to have an air bubble in this viscoelastic, but sometimes we get that. So I'm going to go ahead with the small nick here. This is the re-grasping forceps actually used for ILM peeling. So I'm trying to do with that Capsulorhexis forceps. So I'm trying to hold off that, you can see. So this makes the Capsulorhexis easier. Grasp and re-grasp. The red glow of the microscope is so good that I can see the extension or the progression of the rhexis.
And with the last case, with the lamellar cataract, you said how you use that to size the
yes,
CCC.
That's almost the same thing,
yes.
But I don't have any measurement here.
Right, so how are you using?
But you can see that the granules, opacities, granules, yes, I don't want to cross that. That's where I put my margin. There is some extension here, so we need to pull it back. So we are trying to pull it back. You can see it comes back. With a little bit of pull, it comes back. So you should not go beyond the boundary of this granules you can see. So this forceps makes my life easier. So again, in this case, I'm not going to do a hydrodissection.
Yes, sir. You're going to do more of an irrigation aspiration and go peripherally and strip centrally?
Yes, exactly. So I'm going to take out this air bubble and the viscoelastic. It's quite thick. You can see this visco you can see. So now I'm going to go straight here. You can see out of 136 degrees, I'm going to go to the periphery first and pull all this material. There is no central nucleus here, but I'll still try protect the centralmost part because you don't hit the posterior capsule. This is a protective phenomenon. Posterior capsule does not rupture like adult cataract, but still there is a chance. Why to take that chance if you can do a little bit different procedure? Now you can see the central disc is remaining. Now you can aspirate with the full pedal on.
Do you often switch? I see you don't switch hands for your subincisional. You just maintain.
I switch. In the previous case, I switched.
Yes, sir.
Here, it looks like my thumb movements can take care of that. Okay. Don't hesitate if you are having a difficulty. In this case, it's coming nicely, so I'm not really moving it. You can see some few strands in the posterior capsule here. And this is where the cells are very, very prominent. You can see.
Yes, sir.
See this? It comes.
And you mentioned that obviously this contributes to the risk of PCO. Do you feel that this also could contribute to a risk of capsular phimosis?
Probably the anticapsule phimosis can form with the cells coming there.
So what do you see as the risk factors intraoperatively? What do you worry about for capsular phimosis, like a small rhexis?
Small rhexis, inadequate vitrectomy, and lens design, as well as this capsule polishing. Okay, now you can see that the right side of the capsule is not clear. So I'm going to switch the hand now. No point in trying with the same hand. Now I'm switching from right to left. So this is the irrigation goes first. So you can see the brownish colored. Yes. It looks like a little bit brownish when you have this co-illuminator of the microscope on. It looks a little bit brownish.
Will you do the PPC first or you put the lens first?
I'm trying to do a PPC first. I'm not happy with the Capsulorhexis here, but I'll try to do a PPC first. So we'll try. If you don't, then we can inject the lens and then we can go ahead. You can see that small opening there. I'll magnify.
Yeah. So sometimes I face at this situation the interverted pupil constriction. Why and how do you check this pupil constriction at this situation?
At this stage, if you have manipulated with the iris too much, then you'll have constriction. Otherwise, there is no reason that you should have constriction at this stage.
Sir, why you don't do hydrodissection here?
It's a good question. Nothing wrong in doing. I trained in India, we have a lot of total cataracts. So when you have a total cataract, you will never know that there is a PC dehiscence, specifically because of the posterior lenticonus. it really did not make any difference in terms of doing a hydrodissection, in terms of reducing the time of surgery, as well as clearing of this capsular cells. That's why I don't do it. But if somebody wants to do a hydrodissection in this type of cases, you can safely do. You know that all surgeons have some kind of preference. So that's what I would say. It's a nice heart there. Good love for Bangladesh. Okay, this is a fine forceps, so you need to have a very fine moment. So we can shave that little bit of heart with the vitrector.
Yeah.
Linear, 1000 to 3000. Great. Okay, can I have aspiration on, please, for a second? Maybe you can put visco there. So now the visco is out. I want the vitrector, please.
Do you use triamcinolone and acetonite to visualize the vitreous?
Okay, I don't use it because better to be minimally invasive as much as possible in terms of injecting drugs and drugs. Second thing is the possibility of intraocular pressure rise. Post-surgery could be an option in this kind of situation. So I don't use it. So now I want everybody to look at the flapping of the posterior capsule. That means I'm still not done with the vitrector here. See that? Mild vibrations. So sometimes the children, the vitreous is so hard, you need to do a little bit more. In this case, I can see that the vitreous is solid. I still see some more fibers there. Okay, now it's kind of stopped. So other thing you can, this is one of the tip everybody can take. When you move like this, there should not be any peaking. See, I'm moving from one area to the other area. That's another sign that you're almost complete. So I don't know, sometimes the air bubble comes, we don't know from where. We really don't know because they're all pre-packed. We need to really inflate that bag. Now it is getting inflated. This is extremely important. Somebody was asking me the question. I need some more visco. It takes liters of visco to inflate the bag after vitrectomy. So I'm trying to inflate it, especially. Oops. I need a empty cannula. When you have a PPC, air bubble is not really welcome. It's difficult. So generally, the hospital gives one viscoelastic. I always insist on 2. So whatever you use, you should insist on 2. One of the things I do a little bit differently is I extend the same wound again to save on additional wound as well as to save on suture. I extend this wound because we have done a study. Scleral or corneal does not make a difference in terms of astigmatism in a kid. Anyway, you're going to take it out in a week's time. Yeah, there is some bubble there, but still we'd like to inject the lens because it's mainly in the superior area. So one of the things I inject this lens rather than using this technique, monarch technique. Reason again, because with each movement, it makes a movement vertically. So I just want to have a full control, so I generally inject that. You can be as low as possible. This lens has a good memory. I will be a little bit eccentric here. So you can see the most important step in this case is the injection of the leading haptic.
Yes, sir. Getting that leading haptic in there.
Once you have the leading gone inside, the trailing becomes just a nudge. Just give a nudge here. It goes back. So give a nudge here as well. Sometimes it doesn't open up. So this goes here, nudge it. So once you have done that, little bit of centration, you can see that a little bit eccentric capsulorhexis here. The anterior, we had a little bit pull there, but still it's covering. You can see that everywhere it's covered. I'm still want the trailing haptic to go into the back. I just don't want it to be there. So go from this area, go behind, push, 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 should go. Anyway, that should be enough. Now I need bimanual on a visco aspiration mode, please. At this stage, if somebody wants to be minimally invasive, you can go with your favorite Simcoe cannula. It's
Yes,
a very old cannula. You will have a very balanced thing. So that's not bad at all because you have a bigger wound there. So you can go with that as well. Just a gentle tap on the lens. All the visco should come. You can see the endothelial coating here. When I'm going a little bit, see that? It's coming. But if it doesn't come, sometimes you can go behind and take it out. It's a possibility. See this? It looks fine. But still, always you'll have some gone behind the lens. You would still have a little bit. You can see that? It's coming. It's coming. So if you really want, sometimes you can go there. You can aspirate everything together. Yeah, that looks okay. Air bubble, please. And we are going with the suture. Never go full thickness because you may be okay immediate post-op. When you take out the suture,
Yes.
I've seen endophthalmitis happening because of this corneal infiltrate going into the intracameral. So
yeah.
it may not look so bad when you do the surgery, but in the long term, think about long term.
Yes.
Go partial thickness like this here, partial, see that it's partial. Here as well, see correctly it's partial. You can go a little bit longer.
Hello, Dr. Ramesh, I have a question that how can you confirm that wound is fully clear of vitreous tagged or
Yes, your pupil will not be round.
Yeah.
That's one thing. And there will not be any peaking of the pupil. And your chamber will be deep. And your A bubble will not be round like this. It may be distorted. Triamcinolone. So that's one thing you can use if you are really not sure. But I personally don't use that.